ready? You got me running.
I am Meredith Hirsh, and this is Working Healthcare. In this episode, you will meet a cardiologist I've known since his days at Jackson Memorial Hospital. He is, in his own words, super ADHD, which has helped him. I like to call it my secret sauce, and it is definitely Dr. David Kenigsberg's superpower. He wakes up every morning for a 6 a.m. CrossFit class, takes care of his patients all day, still takes call, still works weekends, and he juggles raising his six children with his high school sweetheart. David is an electrophysicist who was inspired to become a doctor by his childhood pediatrician. He is at the height of his career and highly involved in advocacy. He even changed CMS rules that took effect January 1st of this year. David gets it done. After 17 years of having his own independent medical practice, he actually sold to private equity in 2024. Hold on to your hat to keep up with us and learn how to create change within our American healthcare system. Because if you aren't at the table, you're on the menu. Dr. David Kenigsberg, welcome to Working Healthcare.
Thank you very much for having me. I'm excited to be here.
I'm so excited to have you here because you and I have known each other for a way long time.
Yes, your husband trained me.
Sorta, a little bit, at least part of the internal medicine track. And then he deviated to rheumatology and you deviated to cardiology.
Yes.
Why did you even choose to go to medical school?
It's a long story, but when I was a kid, I used to get sick a lot and I developed, like regular childhood illnesses like, croup or flu or strep. And maybe my mom was a little overzealous with taking me to the doctor, but...
Well, she's a Jewish mom.
Exactly. Thanks, Ma. And I got to know my pediatrician very well. And he was an amazing person. He had a great personality, great bedside manner, was very professional. I had a lot of admiration for him. And I said, you know what? When I grow up, I want to be like that guy. And as I kind of went through my schooling, I was a little bit of a troublemaker. And one day, my mom came to me and said, listen, you could either settle down and get good grades and be something, or you could end up in prison. And
Really? What did your dad do?
My dad's a forensic accountant and owned a bunch of delis in South Florida, Pumpernicks.
Oh, really?
Yes, that was my dad.
Love pumpernicks, but I would think that you are probably the opposite of a forensic accountant.
That is correct.
So you decided not to go to jail.
Correct. And focus on my studies. And I was accepted out of high school in the 6-year med program at University of Miami. And during the summers around that time, I spent my time following a family friend named Malcolm Dorman, who was a cardiothoracic surgeon. I went down to the Miami Heart Institute and watched open heart surgery from 5 in the morning until 6 or 7 at night with this guy every day during the summer. And I really enjoyed cardiothoracic surgery, and I thought that was going to be my future. And then...
So you knew at a young age what you wanted to do.
Yeah, I knew I wanted to do medicine. And then I kind of just lucked onto, following Dr. Dorman around. And then one day, Dr. Dorman said, I don't have any cases today. Why don't you go hang out in the cath lab? So I went to the cath lab and they were doing all kinds of cool things. They were shooting lasers into the myocardium to try to increase blood flow. They were doing stents. They were doing PFO closures, all kinds of interesting things. And the procedures were really quick. And I may have an element of ADD, so quick procedures may help me.
That makes so much sense because every morning at 6 a.m., you are working out.
Yeah, that keeps me grounded. And as I tell my wife, it makes me a better person.
And you have 6 children to orchestrate.
Yes. And
which I actually think is your biggest claim to fame, are the 6 children,
Absolutely.
as opposed to everything else you've done.
right now, my children range in age from 16 to 25. My eldest daughter's married. And 2 of my kids are interested in medicine. One of them is doing biomedical engineering. I have an accountant. And I have a very lively household.
And you're married to your high school sweetheart.
I am. And Susanna and I have been together since 1993. Started dating Valentine's Day 93 and got married in 99, 2 weeks after I graduated med school.
That's amazing. So she has gone through all of the medical school training with you, undergrad, med school, residency, fellowship. Is there there must
2
be a fellowship.
fellowships. So we did a fellowship in Michigan for 3 years, which, being from Venezuela, she didn't appreciate the weather too much.
No.
And then 2 years in Richmond, Virginia, which she told me, David, I love it here, but it's very rural. So we had to come back to South Florida.
An understatement. And she has carried 6 children for you.
Yes. And now she's getting
amazing.
her PhD. So
Amazing.
yeah.
So that is another claim to fame. And so you decided you wanted to be an electrophysiologist.
Yeah, so during my cardiology fellowship, I thought it was going to be an interventionalist, a quote unquote plumber. And then one day I met an electrophysiologist in the elevator. And he said to me, do you want to shoot coronaries all day or do you want to use your brain? And I'm like, wow, what is he talking about? And I did an electrophysiology rotation and then I fell in love with it. And that's what I decided to do. And then I went to Richmond and learned under Ken Ellenbogen, who writes the textbook in the field on devices. And the late Mark Wood, who was an amazing ablationist, wrote a textbook on ablations. And it's really my passion. If you have to ask me professionally what I do every day that just makes me happy, it's being in the lab doing an ablation. That's, for me, like a Zen moment. We have, the staff is relaxed. We play some nice music. And we keep it light, but we take really good care of very, very sick patients.
What kind of music do you play?
It ranges from Bad Bunny to classical music.
I could
80s
see the
rock,
Bad Bunny part.
80s rock, Pearl Jam.
That's awesome. I could see the Pearl Jam. I don't know if I would have seen the classical music, but definitely see you up that Bad Bunny
Yes.
route. The reason why I really wanted you on this podcast, besides the fact that I adore you and Susanna and everything that you have created,
Thank you.
when we've seen each other year after year at the Florida Medical Association annual conference. And this year I interviewed physicians and did many clips on my keynote question that I ask in every podcast episode. If you could create one change in the American healthcare system, what would it be? And your answer was fix the physician fee schedule. Why did you answer that?
Well, I think taking care of patients is a beautiful thing. I think being a physician is a calling. It's more than just a profession. People who go into it do it because it's their passion. But we don't have other opportunities usually to make a living. I have 6 children to support. I do very good, high-level quality work and do my best to take care of patients. I need to be paid for it. If I'm worried that I can't pay my mortgage, how am I going to focus on Mrs. Smith's ablation? I really think that nowadays you have doctors, especially pediatricians, who make it the lower level or lower part of the scale of physicians, worried about how they're going to pay for their car or their rent. And I think that's absurd in the United States of America in current era. And I think that as Americans, we demand the best in everything. We're a society that, nobody wants to wait 6 months for a hip replacement like they do in Canada. But by the same token, patients don't recognize how much the insurance company or Medicare is paying for that hip replacement because they're responsible for their premium and they're responsible for their copay. And whether or not the doctor gets paid $1 or $1,000 for that 6-hour surgery, they don't know. It's the only field that I know of, professional field, where the consumer is not the one paying for the service. And so I really think that I'm not saying that physicians should be driving Lamborghinis and raping the system. What I think is doctors should be paid appropriately for their work. And I could speak to my field because I'm intimately involved with the knowledge of how much doctors get paid for the different procedures that I do, like the implantation of cardiac devices and ablations. In the past 5 years, atrial fibrillation ablation, which atrial fibrillation is the most common arrhythmia in the United States, and as we live longer, more people will have AFib ablation reimbursement has been reduced by over 40%. Mm-hmm. And the cost of living goes up every year. Mm-hmm. So if I spend 60 or 70% of my professional time all day doing something, and you drop my reimbursement by 40%, and I employ 35 people, how does that business sustain?
So I don't think a lot of people who are outside of what you and I do, because you started your medical practice, Mark and I started our medical practice. We are highly involved in the business side of medicine. But reimbursement, if you look at figures from 2000, when you were still in training, to 2026, which was where we are right now, the reimbursement has decreased, considering inflation, by 30% overall. That's across the board. And so some specialties, obviously cardiology and interventional cardiology, which is what you're in, has decreased even more than some other specialties. Pediatricians are making $80,000 a year. And while people on the outside might say, hey, $80,000 is a really good living, well, how many years of post-high school training have these doctors gone through to make $80,000 a year? They have delayed gratification. They are graduating now, on average, with $300,000 in debt. And they're in their 30s when they're finished. And so they've already started a family, many of them by that time. And how do you even dig yourself out of all of your academic debt that you have? So looking at the physician fee schedule, we're losing our best and brightest to Wall Street. What can we do?
Yeah, so I think understanding that the current formula by which physicians get paid is broken. I mean, it's basically a pie, and all they do every year is redistribute the pieces of the pie.
Who gets the money?
The majority of the money is not going to doctors. It goes to insurance companies, healthcare systems, hospitals, drug companies,
pharmacy benefit managers.
Yeah. So it's not going to the people providing the care. And I think until that gets fixed, and when I talk about that pie, I mean, I'm basically referring to physician reimbursement. If next year orthopods make more, cardiologists make less.
Right.
It's a zero-sum game, and it's unfair. And I think, a lot of the formulas that they use to decide on physician reimbursement are very silly. If I do more of something, then I get paid less for it. I mean, as disease processes become more ubiquitous, like atrial fibrillation in my world, we're going to do more ablations. Mm-hmm. That's how we fix people. So it needs to change. It needs to be fair. It needs to be in line with inflation. Or the American people have to decide, you know what, we're okay with mediocre healthcare. We're okay with waiting 6 months for an open heart surgery.
Well, what's going to happen is we're going to have a two-tiered system. So, and that's what they have in England, and that's what they have in Canada. So you can have the government health system, and you can wait 6 months or a year, or maybe if you hit a certain age or threshold with your health, you actually don't receive the care. You are denied treatment.
65. No more dialysis like in England. I don't see I see Americans getting on the streets and picketing if that occurs. I don't see Americans taking that down, so to speak. So sitting down, so to speak. So I think that is one way to help physicians and getting the best and the brightest. We have a lot of burnout in medicine. Doctors' hours are longer. The electronic medical record, which was there to try to improve efficiencies, have actually made doctors work longer. When you go see a doctor, unless they have a scribe, the doctor's looking at the computer and typing on the computer the whole time. That doesn't make for, the warm and fuzzies for the patient. I mean, you really lack the old, like Dr. Kaufman used to do to me, put his hand on my shoulder, talk to me, look me in my eye, talk to me and treat me like a person. So I really think that a lot has to change. And the only way it's going to change is if doctors are empowered and doctors speak up for themselves and doctors get back to the table. I say this all the time when I give talks about advocacy. If you are not at the table, you're on the menu. And for years and years and years, doctors have been on the menu. Personally, I'm sick and tired of it. So I've been involved with advocacy since I was in training. Every place I've lived, I've been involved in advocacy. I'm the current president of the Florida chapter of the American College of Cardiology, the Florida ACC. And prior to that, I was the advocacy chair for over 10 years. And I believe strongly in this. And when doctors come to me in the doctor's dining room or at a restaurant, or I run into them and they complain, I say, well, what are you doing about it?
Exactly. And that's what challenges me. So I was just up in Tallahassee with the Florida Society of Rheumatology, and we have funding to allow 20 doctors or practice administrators or those involved to go up to Tallahassee, to reimburse them for their flight, to pay for their hotel, so it doesn't cost them actual out-of-pocket money, although they are taking 2 days off of seeing patients, which actually is the real hurt financially. And we only had 12 people show up this year, 12, and we could have 20. It was actually the lowest number that I've seen since I've been going to Tallahassee with FSR. And it breaks my heart because people want to call me or talk to me or ask me my opinion about this issue or that issue, and they don't even sit at the table. What can they do at a minimum if they want to remain independent or if they want physician care to be at the highest level that it can be at in America?
So first off, you go to the fly-ins, you go to the meetings, you go to Tallahassee, you're involved in your chapter, you're involved in organized medicine. If you can't do that, and it's time is a problem. I mean, for me, for instance, there's a Florida chapter ACC meeting, there's the national ACC meeting, there's the there's the Heart Rhythm Society meeting, there's the Florida Medical Association meeting. I mean, you can spend all your time and weekends going to meetings. That doesn't work either. Then you don't end up taking care of patients. So you should be involved in organized medicine PACs. Give money to the PAC. You should be involved in local medicine. For instance, the Broward County Medical Association or the Palm Beach Medical Association. Right, you were the
president. I think at the time that Mark was the president of the Palm Beach County Medical Society, because we went and supported you with the Broward County Medical Society. But nobody does. And actually, I also just went to, in December, the Palm Beach County Medical Society annual gala event to raise money. Lowest numbers that I've ever seen. And doctors who were involved are no longer involved. Why do you think?
I think that people have developed apathy. People may have given up. The people that were most involved are the older physicians that are retiring. Younger doctors, they're looking for shift work. They're looking to clock in and clock out. They see this as, more of a 9-to-5, no weekend kind of job. And if you're not engaged, then you're not going to spend your free time doing these things to make things better. You kind of resign to the fact that it is how it is. I'm not going to change it. And at the end of the day, the people that lose out are the patients. Because if we're all not enthusiastic about what we do, if we're all not empowered to do better, if we don't, think about this as a calling and a profession and something beautiful to help society and patients. And it's just a 9 to 5 job where you go in for a few hours and you leave and you forget about it. At the end of the day, the patient's going to suffer.
Is it possible for medicine to be a 9 to 5 job?
I don't think it could be done well if it is. If I don't think that in most specialties, doctors take their work home with them. And the reason that is because you actually have an attachment and a care for the patient. If your patient doesn't do well and it doesn't bother you, there's something wrong with you. You're not a good doctor. And so I think that we should, I take my specialty to heart, pun intended. Yeah. But we should be caring for our patients. We have, call. I get called, I'm sure Mark does too, all the time if I'm not on call or after hours about patients, because who else are they going to call? I mean, patients don't present with illness from 9 to 5.
You have 6 kids. You're married. Your wife is educated. She's now going back to get her PhD. Some of the younger physicians listening to this episode are going to say, well, they did it back in your generation, and you and I are not old. We're in the height of our careers right now. So what do you say to those who are like, listen, I have 6 kids. I have a married life. I have to take care of my family, and I also started my own medical practice, and these are the hours that I've worked. What do you say to them when they look at you like, that doesn't happen anymore?
I would say,
the reason I ask, selfishly a little bit, David, is because I'm struggling right now with all of the physicians that we've hired. Nobody else is involved in advocacy, and you know how passionate Mark and I are about it. And they all want to remain independent. They all want to be a partner in this practice, but they're not stepping up to the table the way that we are. We have 3 kids. We had to go through all of this. And they're like, maybe in your generation, you did that.
I really think, it's basically you get out of things what you put into them. And if you want to have equity in a business, then you need to sweat. You need to put in the sweat equity.
And what is sweat equity? What is that? What does that look like?
It means that you take ownership, you take pride, you put in the hours, you treat it like it's your own. You make sure that if, your senior partner is out of town, that you make decisions that are in the best interest of the practice so that things can keep moving while everyone is not there. So I think that, one thing that I've noticed about people that like to complain but don't like to work is when they're put to task, they always have an excuse. I think one of the biggest answers to your question is there are no excuses. Like I normally say to some of my staff, tongue in cheek, get her done. Like do whatever you need to do to get this done. Take care of the patient. And yeah, you may have to stay an extra hour. You may have to work a weekend that you didn't expect to work. It is what it is. That's what being a doctor, being in healthcare is about.
Yeah, but you do that in your everyday life. You go to the gym every day at 6 a.m. It is part of your ritual. And you're still married to the same woman that you fell in love with in high school. What has Susanna had to give up for you to be able to do this? What has changed, or have there been any negative impacts because of your constant drive?
Absolutely. My wife, my kids, my mother have all told me the same thing, that I lack the ability to stop and smell the roses, that I'm always on to the next thing or thinking about something else.
Yeah, but your dad was the Pumpernicks owner. I mean, come on. I think this came naturally to you, whether it was nurture and nature or...
Yeah, my dad never had a day off. Yeah. I always say he worked harder than I ever will. I think that, I have always had an interest in trying to do better. I'm always my biggest critic. And so that comes with a negative. I mean, it puts a lot of pressure on a marriage. It puts a lot of pressure on children. I mean, you know, if your dad is always going 24/7, how do you feel comfortable sitting on the couch after a day of school?
But isn't that positive?
It could be, or it could be negative. And I think the other thing is, if I go on a vacation, it takes me 4 days to kind of get back to like chill, to turn it off. I mean, I'm always on, and I don't expect that from everyone, but yes, it does come with a cost. And I think the only way I'm able to do this is with the balance. I have a family, I do exercise, I have hobbies that I like to travel, but when I'm working, I'm fully engaged, and I'm trying to figure out how do I make things better? How do I make it better for my patients? How do I make it better for my colleagues? How do I make it better for my group, for my practice, for whatever it is I'm doing? And I think if you have the drive to do that, then you will make progress. People will say that you've done something. And we talked about advocacy. I've been involved in advocacy for a long time. I've been working in a surgical center since 2019 in an ASC. We do most of my partner Ahmed and Osman and I do most of our outpatient device work there. It's an amazing experience for patients. They drive up, they walk in a few paces. It's a beautiful place. It looks like this. They get their pacemaker, their defibrillator, couple hours, they go home. There are no long hallways. There are no patients with all kinds of communicable diseases. During COVID, it was an amazing place. I could have one patient come in at a time and not be exposed to other COVID patients. And we're about to embark on doing cardiac ablations at the ASC.
But why? That's what I really want to get to. And it's all because of your advocacy work, because while you have an amazing ASC, you haven't always been able to do all of the procedures in there. And you've been involved in advocacy, and you are a huge supporter of physicians and supporting physicians for what they do. What did you change? What laws have you changed in the state of Florida so that you could provide that experience to patients?
So Florida is a state that doesn't require a CON, or certificate of need. So the ASC is allowed to provide many services in POS 24, which is a CMS dedication that allows payment in a site. However, they have not allowed us to do cardiac ablations in that ASC setting. And we have a group of us, EPs from around the country, myself, Dr. Arash Ariana, who's in Sacramento, and Dr. Vijay Swarup, in 4 years ago, got together and decided we were going to start a grassroots campaign, and started a nonprofit called the Arrhythmia Intervention Society, which the goal was to change CMS, to allow CMS to pay for ablations in the ASC and petition the bodies that govern our specialty, the Heart Rhythm Society and the American College of Cardiology, who was already pretty much on board, to ask CMS to allow us to do ablations in an ASC and reimburse for it.
Where were they done prior?
Only in the hospital setting.
So obviously being in an ASC setting is much more comfortable for patients.
It's more comfortable. It's about a third cheaper for the healthcare system in general. So procedures done in an ASC are usually about 30% cheaper than what's done in an outpatient hospital setting.
So why was it not allowed? What was the reason?
To be frank, the American Hospital Association lobby.
Okay.
They're probably the strongest lobby in DC, and they lobby hard against.
And in Tallahassee, by the way. That's what I learned when I was up there in December.
I mean, and it goes back to our conversation about advocacy. If you can't go to the meetings, give money to your PAC, because the AHA has a ton of money. The AHA Hospital Association has a ton of money to pay for people to advocate, to pay for lobbyists, to do all the things necessary to get laws changed or stay the same in their favor. So we my mentor, Dr. Ken Ellenbogen, was the president of the Heart Rhythm Society, and he was gracious enough to listen to me and my colleagues with ACE and formed something called the Heart Rhythm Advocates, which is an advocacy arm of the Heart Rhythm Society. And all of us together got together and advocated for this. And in July, after a series of meetings with Medicare, with people that oversee Medicare, we were able to get the preliminary ruling that ablation codes would be paid for in the ASC. The final ruling came out last month, and starting in January, me and my colleagues will be able to do our ablation work in the ASC setting, which is
on a national level.
Nationally.
That's amazing.
Which is huge for many reasons. It's good for patients. It's good for the healthcare system economics. It's good for physicians who want to be entrepreneurial and own an ASC or own part of an ASC. They get to partake of not only the professional component, but also the technical component. And even if they don't want to, it's been shown in the literature that specialties that have procedures that they can do in an ASC actually show improved reimbursement by private payers and improved pay by whoever their employee is, be it the hospital or big systems. So it kind of, helps all of us to do better in cardiology. And I think that's really amazing.
At least in the world of rheumatology, I would say our similarity would be infusion, right? Our infusion suite. There are hospital options, and then there are private practice options. We don't do it in the ASC, but I'm using infusion as a commonality with the ablation. If an insurance company does not want to pay for a patient to get infused within our practice and at our infusion suite, we've said, fine, we'll send them to the hospital. It literally costs 4 times the amount to send them at the hospital. But now they've kicked back to us and say, fine, send them to the hospital. The hospital requires us to do all of the coordination and the prior authorization work if we send the patient. So the problem is we can't do that. We can't afford to do that. We can't do all of the work for the hospital and then lose all of the work product by sending it to the hospital. So then we look at it and go, what do we do for the patient? Because whatever option we choose is not appropriate. We don't want to send the patient to home care, so United Health Group can go ahead and send their nurse practitioner, or even I've had LPNs go out to patients' houses and infuse them with some drug that could have a lot of side effects. It's insane. I sit there, you're a doctor, so please help me. What do you do for patients in that situation where you're going to lose money if, and I'm the business side, you're going to lose money if you infuse the patient in the office. It's going to cost the system 4 times more if you send them to the hospital, but you're going to have to do all the work, which doesn't make sense. Or you send the patient to home health, and that's the worst option for the patient for their actual health care. What do you do?
I mean, at the end of the day, you're responsible as a physician or healthcare provider to do the best thing for the patient. But I do think that it's very important, and I've started to do this. I try my best to educate patients to be advocates for themselves as well. Mm-hmm. And it's very common now in cardiology and electrophysiology that a lot of the insurance companies, especially in South Florida, which is the home of the HMO, have decided to kick expensive providers off their panel to reduce costs. So if they know that I'm an ablationist, they don't want me on their panel because then they know they're going to have to pay for ablations. So if there's no ablationist on their panel, then they don't have to pay for ablations. So patients will come to me and say, I got a letter from my insurance company and they say you're not going to be part of the insurance. You no longer accept insurance X starting in January.
Right, they like to blame you.
Yeah. So I want to tell them something, and I say this all the time. I'm like, let me explain something to you. I started my practice in 2007. I've been on every insurance company that will allow me to be on their panel. Okay, whether or not they give me 70% or 100% of Medicare, I have accepted every insurance company as something that I thought was important to give patients access to my care. Having said that, over the years, year after year, insurance company after insurance company kicks me off their panel. I'm triple boarded. I'm at the top of my game when it comes to procedures. I'm very well respected in the community. It has nothing to do with the quality of the care that I provide. It has to do with cost containment. So my advice to you as a patient is shop around. If you were going to buy a car, you would shop around. Why don't you shop around for your healthcare? Why don't you figure out, are all my doctors that I like, that I've seen for 6 years or 10 years on my plan? If not, let me get another plan. And to be honest, my office administrators are surprised by how many patients will switch their insurance when it's time for open enrollment.
Mm-hmm. If they can. If they can.
Yeah.
Right. So,
and my other advice, I'm sorry to interrupt, my other advice in South Florida is if you can afford it, go straight Medicare.
100%.
Yeah. I mean,
I call it Medicare disadvantage.
Yes. I mean, basically they turn in their Medicare card for, a free shuttle to the office. Whereas, Medicare is probably the best payer in South Florida and allows you the most access.
100%. But I'll tell you, I shared this story on Mark's episode last week about my mom because my mom needs a cardiologist and she lives in the panhandle of Florida. And it is very difficult to get her scheduled. And there have been so many loopholes and hoops I've had to jump over to actually get her care. As of now, she still doesn't have an appointment with the cardiologist. They want to set her up with a nurse practitioner, and she's on traditional Medicare. So I don't know what to do at this point. I mean, I said to my mom, even when she decided to move back there 2 years ago, I said, I just want to let you know, Mom, if you stay in South Florida, I can help you. If you move to the Panhandle, my hands are tied. I know a lot of doctors in that area, and I'll do whatever I can, but cardiology, I don't. So we have to talk after this podcast because, man, am I having a hard time. But it is difficult because we do have a huge bleed issue when it comes to physicians. You went into practice and opened up your practice in 2007, the same year Mark and I did. And I'm telling you, it's hard. You last year, though, July of 2024, sold your practice. Tell me a little bit about that and why you chose to do it.
Yeah, I mean, sometimes you can see the writing on the wall. And I think the way that physicians have been reimbursed and the way that things have happened as far as managed care, private insurers, and Medicare and Medicaid, it was apparent to me that there's a national undertone of trying to do away with small private practice groups.
Yeah.
And the options for someone like me and my partner were work for a hospital, which I don't think I have the right personality to do.
And once you own your own practice and you're the boss, I don't know if I could ever work for anybody else either again.
So that wasn't a good option for me. Join some other large entity or other large group, which in South Florida and in northern Broward County, where we're located, there are not a lot. Or explore what's out there as far as private equity. And at the same time, a colleague of mine, Dr. Kenny Zelnick, was thinking about the same. And we kind of got together, him and his partner, me and my partner, and started brainstorming about options. And one of those options was to join a cardiovascular specific private equity group. And for me, that resonated because cardiology is a very unique specialty because we have cardiologists who are very procedurally based, like interventional cardiologists, structuralists, and electrophysiologists. We have clinical cardiologists that do a lot of imaging. There's a lot of ability to have access to revenue from ancillary services like the imaging, like echocardiograms, nuclear stress tests, PET scans, PET CT, and so forth. We do lots of monitoring. So having thought about all the options, as a group, we decided that a cardiovascular private equity partner would be the best choice.
Why did you decide, though, you needed to be out? I understand you're saying the writing's on the wall. And trust me, this resonates with me, and I'm struggling because you started your practice and then added a partner. At this point, Mark, because in the state of Florida, if you have an S corp, it has to be physician owned. If it is a doctor group. So Mark is the only owner, 100% owner. We would love to have partners. We would love to have somebody buy into the practice. We're not giving it away, right? You need to be, this is our business that we've built for 18 years. You need to buy into the practice, and we would love that. But it goes back to how our podcast episode started. I don't know if there is the drive and the work ethic and the dedication to want to just get it done and do what needs to be done, especially in 2026, to run an independent medical practice. But we're looking at the long game too. Where is healthcare going in this country? And the reimbursement is constantly being dropped. We're having to do more with much less, and there's a huge administrative burden. And so we're looking at all of this going, what are our options? So you and I are about the same age. Why did you decide you could no longer continue independently?
So everything you just said is factored in. Increasing overhead, decreasing reimbursement, increasing administrative needs. But one of the big ones is if there is economies of scale that a 2-man group or a 4-man group cannot benefit from. There are abilities to negotiate with insurance companies when you're 10 guys or ladies, as opposed to when you're 2 for reimbursement. You have some kind of bargaining power that's much greater exponentially than a smaller group. You can contain costs. There's economies of scale. There's lots of things that can be done as the group grows. And so in looking at the marketplace, the only way to grow a group organically is to go out and hire people that want to work in a private setting. And as you mentioned, it's hard to find the right people. In addition, like I mentioned, EP lost their value, so to speak, by a reduction in ablation reimbursement by 40% over the last 5 years. And so in order to kind of spread the risk or spread the benefit, you need other specialty or subspecialties of cardiologists in your group in order to make up for that. So keeping all those things in mind and kind of reading the tea leaves about where private practice is going in general, it seems to me, and I still believe this a year and a half in, that a large specialty-specific private equity partner is a very viable option to continue to grow and benefit from the work that you're doing and get benefit from, like you said before, the work product of what you're doing. For instance, if I put in a defibrillator, I also want to benefit from the remote monitoring. I'm going to be monitoring the patient remotely. There's value in that. If I'm going to order an echo, I should get value from performing the echo and reading the echo, aside from just the professional component. And
so that's economies of scale. That really is. What about an MSO, a managed service organization? Had you thought about that option?
I think that is also another viable option. I do think that over the years in South Florida, I've seen a lot of them come and go. And so you kind of have to also see what is in vogue or in favor. And I think in cardiology, everything is a bubble, right? the bubble now in private equity is cardiology. And so if you get involved at this point, it's probably the most lucrative. That when that passes, then there'll be something else.
How has it changed the way that you practice medicine or the care that you're able to deliver to your patients?
I think that on a day-to-day basis, it hasn't changed anything I do. I still go to the hospital and do procedures. I do my procedures at the surgical center. I do see patients in my clinic. I am as busy or busier than I've ever been clinically. I also am the president of the group, so I do have an added responsibility of some additional administrative roles. But I also am now starting to kind of take a step back and look at the big picture of how can we do things better now that we have more physicians, more NPs, more staff. How can we streamline certain processes? How can we get paid more for the same work that we were doing before by doing it more efficiently or negotiating better rates? So I think what this has allowed me to do, with the benefit of our private equity partner that has a lot of resources as well and wants to bolster our ability to do well financially, is it allows me to run this more like a real business than a mom and pop business.
Mm-hmm. Is it physician owned? Are there any physicians that are part of the private equity group?
So there are 451 cardiologists that own the group.
Okay. And you said private equity back, so there must be investors as well.
So Webster is the money behind it.
Okay. All right. But it's still owned, physician owned.
Yes.
So you're still able to have control of it.
Yes.
And you must have kept part of your local equity as well.
That's correct.
Okay. I mean, that's what I'm thinking. If you keep local equity, you still have drive and desire to continue to push the bubble and help and do what needs to be done. And it doesn't change what you're doing as an independent physician. It just, as you said, it helps me with economies of scale and gives me more power as a giant than feeling like you're David in David and Goliath fighting all of the time.
Absolutely. And I mean, there are concepts, ideas, business ideas that I never really thought of that we've added to the practice. And I think that definitely helps the bottom line. It also helps patient care. For instance, there's a code to be able to follow someone's blood pressure remotely, and that's reimbursed. There are 300 some odd patients in my practice that we identified that we can do that for. It's going to help them clinically, because millimeter per millimeter of mercury that you reduce someone's blood pressure, you reduce their cardiovascular risk. So there's a benefit to the practice. There's a benefit to the patient. There's a benefit to the healthcare system. Less patients have strokes or heart attacks. So it's a win-win. And I think that having this partner, you know, when people have businesses, they can look for investors or they could look for smart money. And I think we have chosen a partner that's smart money, that allows us the autonomy to do what we were doing, but gives us a lot of resources and ideas of things that we could do better.
And I love the idea of generating ideas. I love to sit at the table with other bright, driven people and find other options, other solutions. Like, let's solve problems together. The older I'm getting, the more I'm realizing I really enjoy being part of a team. I don't want to sit at the top isolated. I really want to be surrounded by other innovators so that we can think of different solutions.
Absolutely. I mean, this organization has quarterly meetings where we go and we meet together, we present to each other, we talk, and I walk away saying, wow, these guys are so much smarter than me. I got to emulate this or that behavior. And I think it definitely helps push you to do better.
So I want to ask you the question again, now that some months have passed since I asked you the original question about creating change in our American healthcare system. Do you still go with, I want to change the physician fee schedule, or have you changed your thought process in the last 6 months?
Yeah, I think that I have changed my thought process. I think the answer I would give now would be, I'd like to empower doctors to kind of take back healthcare, to realize that we should be the ones driving how healthcare is run in this country. We should be making the decisions. We should be making not only the clinical decisions, we should be making the business decisions in running healthcare in this country. And I think the number one term that I would use for what I wish that we would reclaim is agency. I mean, it's a big buzzword now in business. Now that I have this role in business, I read a lot of business journals. We really need to reclaim agency. We really need to understand that we are the driver and we have a lot of responsibility on the clinical side, but we also have a lot of ability to do well for ourselves and make the system better if we put in the time and we empower ourselves and others to do what we need to do. I think the doctors that you were describing and we were lamenting earlier on in the conversation, those are not the leaders of tomorrow, and those are not the doctors that I want to take care of me.
Dr. David Kenigsberg, thank you for joining me on Working Healthcare.
It's been a pleasure. Thank you.
If this conversation hit home or made you think a little differently, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. Connect with me on LinkedIn to keep the conversation going in between episodes. If you've got a question, an episode idea, or someone you think I should feature, send me a note at meredithhirsh.com. Thank you all for the 5-star reviews. They help more listeners find the show. New episodes drop every Tuesday. Subscribe so you don't miss what's next. Tune in weekly as we explore the inner workings of healthcare, because you can't fix what you don't understand.